Let's dive right into this explainer on the operative steps for a small bowel resection and anastomosis.
We'll tackle this in 4 key phases: exposure, resection, anastomosis, and finalizing. Let's go.
We start with a midline laparotomy. This gives us the wide-open access we absolutely need. Next, we systematically run the bowel from the ligament of Treitz right down to the ileocecal valve.
To mobilize the segment, we divide peritoneal attachments and carefully dissect the mesentery to expose its vascular roots.
See this? We double ligate and divide the feeding mesenteric vessels to strictly prevent any operative bleeding.
Then, we apply non-crushing clamps to healthy tissue and cleanly divide the diseased segment.
Crucial safety check here. We must visually confirm those remaining bowel ends have a robust, viable blood supply.
Now for the reconnection or anastomosis. We can use either hand-sewn or stapled techniques.
For hand-sewn, we meticulously suture the posterior wall first, followed right after by the anterior layer.
Anteriorly, we use an inverting technique, like a Connell or Lambert stitch, to securely tuck the mucosa inside.
Alternatively, linear staplers efficiently create a functional end-to-end anastomosis by rapidly connecting the segments side to side.
For lower colorectal cases, we insert a circular stapler through the rectum, join it to the anvil, and fire.
Almost done. Before closing the abdomen, we absolutely must run through our final safety checklist.
First up, suturing that V-shaped mesenteric defect completely closed. This strictly prevents post-operative internal hernias.
Next, we do an underwater air leak test to ensure our anastomosis has a perfectly secure watertight seal.
Finally, we verify complete hemostasis across all surgical sites. Literally no active bleeding is allowed.
So, consider this. What devastating, life-threatening complication could arise if you accidentally forgot to close that mesenteric defect?